And we're back again. I'm trying to get these little episodes out sooner and sooner. Bear with me through the technical stuff. But I'm back with Dr. Peter Pfeiffer. He is an anesthesiologist. I'll let him describe himself in a minute. But I've worked with him now for, was it a couple of years at least?
Yeah, at least that.
Yeah, so I definitely have experience working with you in the office-based anesthesia scenarios, but I have been working with anesthesiologists pretty much all my career. The main topic, essentially the broad topic, would be like, I was thinking like medical emergencies in the dental office, and also possibly, anesthesia issues, airway issues, laryngospasm, things like that. Shock, allergic reactions, things that we can definitely see in any office, but in our settings, dental, medical, things like that. And having an expert anesthesiologist obviously here also helps. I'll let you introduce yourself really quick.
All right. Thank you. Peter Pfeiffer. I'm a board certified MD anesthesiologist, and I have been doing dental and oral surgery office only anesthesia for the past about 10, 11 years, I guess.
That's it?
Yeah.
Oh, that's right. You were in the hospital before.
I was in the hospital first, yeah.
You only been working 10 years? That's nice.
No, longer than that.
Okay.
20, actually.
Yeah, so like we're talking about emergencies. We're going to talk about a lot of that stuff today. So without further ado.
LFG.
Buttermilk biscuit, here we go. Sip the flour
Roll
over
the dough.
We're in.
All right, we're back. I'm an oral surgeon, as a lot of you already know. Maybe you're listening for the first time, you have no idea. I also did medical school and dental school, so I did both. I went to a program that had both involved. And through our rotations, we also, we do at least 4 months on anesthesia, running our own rooms and things like that at first with somebody. In my office, I do a lot of IV sedations. We give pretty much a lot of things that you'd normally get if you're having a GI procedure done. Fentanyl, propofol, Versed, ketamine, things like that. That's pretty standard as far as what we do. We do bring in anesthesiologists, in our group, and it makes a lot of sense. And there's sick patients, there's little kids, there's people on chronic narcotics, there's multiple medications, cardiac issues, like anything, that would warrant, deeper level of sedation, airway control, things like that. It makes a lot of sense. Longer procedures, procedures where there may be more blood loss than, that you feel comfortable and without an airway, present. So yeah, there's a lot of reasons to bring them in. In the past, I would say even like the 17 years since I've been working, I've noticed the trend for dentists and periodontists and other specialists, pedodontists, to bring in anesthesiologists also. So I think this has been a growing trend. And as far as anesthesiologists going into dental and doing a lot of cases with them. But as a specialty, and you had mentioned you work with a lot of oral surgeons as well, but oral surgeons do have a lot of anesthesia experience, whereas I think, the pedodontists, some do a little bit, but periodontists, and so forth, they may not have that experience. They just kind of bring people in and have them do that, but they don't really know the in-depth of it as much, I would say.
Yeah.
Does that make sense?
True. Yeah. I think that's really true. In fact, many of the periodontists, very specifically talking about perio, many of them have good experience in sedation, but as far as being in the operating room and patients intubated under anesthesia, not as much as the oral surgeons, I would say, training wise.
I just think knowing that and being on the other side of it, working, the other end of the table, we have an idea like, being efficient, not wasting time when the patient's under anesthesia. I mean, you guys are literally billing every 15 minutes, right? That's usually how it works.
That's right.
I mean, you do the first 30 minutes or whatever and then each additional 15-minute increment is billed. Mm-hmm. So the more efficient the surgeon is, the better, the less the patient essentially can have to pay sometimes.
That's right. Yep.
So all that plays into effect. So I have an idea of how all that goes. So I try to be really efficient while doing exactly what I need to do, when I'm doing cases with an anesthesiologist. I teach at a dental school. I volunteer teach. I've been doing that for quite a while. I read some studies. I got all these studies in my head. I read a study on issues in the dental, like what are the most common medical emergencies seen in a dental office? And at least 50% of those were syncope. All right. Or even pre-syncope, but syncope. And for what that really is, people fainting, so I've had patients faint. I've had the ride of a patient faint before. Yeah, they just come back to pick their son or daughter up, and they just get queasy and they faint and they pass out from standing. I've seen dental students faint I've seen it when I was in dental school. We were learning how to give injections, and one of my classmates was just watching an injection being given, and he fainted from a standing position. And just recently, I teach at the dental school. I saw dental students were working on a patient. I was in the clinic, and I saw one of the dental students get queasy. So, yeah, we did seat her down, put her up, and do all the things we need to do. But that definitely happens. I don't know. You must see it a lot.
Yeah. I mean, when I'm in the dental office, as often as not, there will be an assistant or like maybe the front desk person comes back in because on the day I'm there, it's sort of like not their usual day. And so they come in and all of a sudden there's a person there that is ashen, looks like they're on the verge of passing out, and they're not used to it being as sort of gritty.
So you've had front staff pass out, you're saying? Like they just come back and look? Yeah.
Yeah.
That's what they get for going back there and looking.
Right, exactly. Yeah.
Stay up front.
Front of the house,
you guys
folks.
doing? It's like, what do you expect to see?
It's funny. Yeah.
Yeah, no, literally, like I had a dental student getting queasy. I could tell you could see the sweat forming on the forehead, and I felt the shoulder really hot. Sat her down in a dental chair, laid it all back, got her supine, got her feet up, got a cold towel put on their forehead. That's really important. Mm-hmm. If they're losing consciousness and they actually lose consciousness, I've had patients look like they're having a seizure when they pass out. It literally looks like if you didn't know any better, like the scenario, you'd think they're having a seizure, and some of them probably could. But I've definitely seen them start seizing. I had one patient maybe like 10 years ago, passed out before the IV even went in, and just thinking about it, got himself worked up, passed out, and he basically had a seizure in the chair. Nobody was prepared for it because, he's not strapped into anything. And so we're all like trying to keep him in the chair so he doesn't fall out of the chair while he's having a seizure. And then like there's a headrest back. There's a lot of stuff going on. Ultimately, the goal is to keep them safe. If you're able to lower the chair to the floor as much as possible, have them not fall out or be in some weird contorted position, and make sure they have an airway, obviously. But yeah, I've definitely seen that. I don't know if you've seen it. I mean, you start in IVs all the time.
Yeah, that's true. I mean, the patients will get lightheaded now and then when you're doing an IV. Luckily for me, they're already in the position I want them in. It's almost irrelevant.
It's no big deal for you.
Right,
yeah,
exactly.
You're going to put the airway in and you're the master
We're already
of that.
there.
Yeah.
I had an
I'm
episode
talking about for a dental,
back.
Dental office. So yeah, it's tough.
Right, exactly. Yeah. I had an episode a while back where I had not yet gone out into the consult room and said hi to my patient, and they passed out cold in there. And I hadn't even been there yet, like I said, right? And so there's alarms going off and everything, and everybody's running around helping this person.
Yeah, so the fainting, I've had a patient just during the consultation fainted. All of a sudden he got up out of the chair, went to the sink for no reason, and passed out right to the floor. And I was able to grab him before his head hit the floor. And then we just laid him on the floor for a while until he woke up. Yeah, so what do? I mean, you put their feet up, right? If you see someone pass out or faint, lay them down if you can, get their feet elevated. They're going to be hot. So sometimes if they're not completely out, you can offer them a cold towel. If we have the blood pressure cuff and things there, I like to check it a lot of times just to see where they're at. Get the monitors on them if they're in the room already. Put them on some oxygen if they need it. Also, be on the lookout for hypoglycemia, just to make sure it's not a low sugar issue or they don't have diabetes or something like that. Right. I always have that in the back of my mind too.
And this actually leads into one of the things that I was hoping to talk about with you is that first thing I would do is I would put oxygen on them and a pulse oximeter. Yep. That's number one. Because as everybody knows probably very well, the number one cause of cardiac arrest is respiratory arrest, right? And so we want to know they're oxygenating. You can avoid an awful lot of problems if you put a pulse oximeter and even nasal oxygen onto a patient.
As an oral surgery office, we have all that stuff there. I mean, if this happens at the dental office, let's say a lot of dentists, if you're doing even triazolam sedation, Valium. I mean, I've seen it happen with pills. So you're not out of the woods if you're just giving patients pills, believe it or not. So if you're not even doing IV and this stuff happens, you need to have in your office at least a pulse oximeter, a portable one that you can put on somebody, a quick way to take blood pressure. whether you do it manually or not, someone needs to be able to do it. And in that scenario, know how to do it. So whether you use a machine or do it manually, but you definitely need a pulse ox, I would say. I wouldn't even do any of these cases if you don't even have that stuff in your office and it's working. Just going forward with that. But also check there if you have a glucometer, you should always have one of those too.
Yep.
Do a quick, blood stick on them if you can't figure out a reason, or if they have comorbidity. I've been performing these procedures since 2010. My first case was with Nobel implants, and I continue to use them today. You can see and feel the transformative difference this makes in a patient's life. Get a second, third opinion, and then ask them, what system they're using. And just do your due diligence. So these are the scarier ones. So we see a lot of patients. I feel like a lot of people, a lot of kids, we see a lot of kids, teens, a lot of people have asthma, right? So there's this thing called bronchospasm. And then there's another word that's laryngospasm. They sound very similar. And I think people can get the signs and symptoms confused. Laryngospasm versus bronchospasm. What do you think?
Well, so people that are not providing any level of sedation or have not been given any amount of sedation, they're not having laryngospasm. Laryngospasm is that no man's land between loss of reflexes all the way under anesthesia and awake patients. If you're only doing oral sedation, you're not having laryngospasm. And so bronchospasm, which is common in a patient that has reactive airway disease or asthma, the bronchospasm patient, they know something is wrong. Laryngospasm patients, something is wrong.
So laryngospasm is basically just to explain to people that aren't in the medical field. Vocal cords, what?
Let me explain it differently. Let me tell you the 4 integral parts of a cough, all right? Inhalation, close the vocal cords, increase pressure in the chest, and open the vocal cords. That's a cough broken down into its pieces. And laryngospasm is a cough gone haywire. The vocal cords lock up and they don't open again. That's laryngospasm. Bronchospasm is contraction of muscles in your windpipe and trachea, and it's involuntary muscles. These are not muscles that anybody has any power over ever.
Right.
And so in that way, it's different. So laryngospasm is like almost choking on a foreign body, more like that. Only
you're not moving air.
The foreign body in question are your own vocal cords.
Yeah, you're not moving any air at that point.
Right.
Everything's quiet, right? You have to get past the vocal cords to get them air.
Mm-hmm. That's right. And you can have a partial laryngospasm and they squeak. You can hear a high-pitched passing of air over those real tight vocal
Does it sound
cords.
like this when they
A
squeak?
little bit like that, yes.
No? Okay.
Kind of.
I had to add that in there, sorry.
Thank you.
I wish it sounded like that. That'd be cool. But no, laryngospasm as far as what we do. And I know oral surgeons aren't the only ones that do their own sedations. There's GI doctors that do sedations, right? For their scopes and things, colonoscopies, EGDs.
They do. I think they
even
don't
some
actually
dentists
do
do
as
them.
much anymore as they used to. It depends on the jurisdiction, but the oral surgeons are kind of the last holdout on what's called the
I know
single
dentists
provider
that do
model.
IV sedations, so it's not.
They do.
You know,
They do, but not deep
there's a study
sedation,
that I was
not
going to
on
talk about if we had
purpose.
time. Yeah, I know. There's a study about that I was going to talk about, But anyways, we're not the only ones that do them. I would say out of all the people that do them, we probably have the most actual training to do them in our residency programs and beyond and stuff. But it's not just, from weekend courses. I can
That's right.
I can give midazolam and fentanyl now. I just don't use probe, but that's not always safe either.
Mm-hmm.
So even oral sedation is sedation, and I have a story, there's a patient, Halcyon. So that's one of those things, Halcyon, triazolam. So if people use it, it's like a newer Valium, I would say. It's the same class if people understand what Valium is. It works differently. I think when it first came out, people were using it like Valium. Oh, I got an airplane flight. I hate it. I'm going to take some triazolam, some Halcyon. And the thing with Halcyon that's different than Valium or Ativan or something is that it has a little amnesia with it a lot of times. And so people would take this on an airplane flight for anxiety and then not realize like 3-4 hours later, like they forget like their flight, they forget who they were talking to, what they were saying. Imagine how scary that is. You like get to your destination, and you're like, I don't remember the flight, what did I say? You know, I had a patient once, we gave, you know, she had Halcyon, and she came for a follow-up visit like 2 weeks later, and she's like, you know, after that surgery, my nephew took me to Costco. You know, we tell them they need to go home, but they went to Costco, and she bought like $500 worth of stuff. She bought all these DVDs at the time, and she's like, I don't even have a DVD player. And like, I bought all these DVDs, like they don't remember. You know, they're like, okay. You know, they don't use it for that reason anymore. Now people use it more as like a sleep aid, or for what we use it for is for some sort of oral sedation in the medical setting. But I remember like going through that when it first came out, people were just overprescribing it for everything, not knowing the amnesia part, you know?
Right. Yeah, exactly. I had a recent episode where patient had Halcyon, and they were utterly convinced that I had not been there seeing them on that day. Yeah.
Yeah, Halcyon's, I like Halcyon. I use it because I like the fact that it blurs the memory a little bit. I think that's helpful in for what we do, but it's not helpful if you're taking a flight across country.
No.
You know. But yeah, so getting back to laryngospasm and bronchospasm, when we do our own IV sedations, laryngospasm is one of the ones, you know, I would say we fear the most, but it's the one that, you know, it's hard to deal with if it happens, because what are you supposed to do? The first thing you can do in that setting, if you don't have a breathing tube already, you know, around you or anything, is you can get the cannula off and put a bag mask, you know, on them and try to breathe for them and try to break it that way with pressure. I would say that would be like one of the first things to do, you know, lighten the sedation, whatever you need to do as well. But that I've had that happen a few times during my career, and that's always generally worked, thankfully. I didn't have to go through any sort of succinylcholine or anything like that. One case, I think I did give a little bit more probe to see if that loosened them up a little bit, and that did work. But generally, like forcing air in there helps, right?
Yeah, you have 4 options when a patient has true laryngospasm. Number 1, first and least invasive technique is continuous positive airway pressure. Whether they're using an advanced airway device like an LMA, or if it's only a mask, continuous positive pressure is useful and usually works. If it does not work,
I'm going to interrupt you real quick.
Yeah.
In a healthy patient without comorbidities, okay,
Yeah.
This is kind of a tough question. How comfortable are you with a laryngospasm, trying to break it that way? And then how long would you essentially wait before you go to the next thing?
Really comfortable.
Like a minute or two?
Yeah, certainly.
Essentially,
Depends
they're not,
on what
at this point, they're not in the 80s or 70s setting or 60s.
Yeah. So
or maybe they are. I don't know.
The answer to that depends on what gas mixture were they breathing prior to that. If they're on 100% oxygen and they're like,
which is what we give,
otherwise healthy person, you've got minutes.
Really?
It's a long time.
Even if they're in the 70s saturation.
No, not if they're there at that point. But
yeah,
when the laryngospasm happens, if they're on 100% oxygen and then they don't breathe after that, you've got a couple of minutes till that pulse oximeter is going to change from
I always think of it like a 45-second delay on the pulse ox. Like if you're not breathing, pulse ox is going to be fine for like 45 seconds, and then it's going to start to show.
Yes.
Same thing if you start breathing again. I feel like it.
And if that fails, then the next step after that is dependent in my mind in how fast it's failing. And so if their pulse oximeter is going down fast, you have to go to the end of the algorithm first, which is paralyze them and open those vocal cords up.
So you're giving succinylcholine or propofol, right? Intubating dose, or do you just go right to the intubating dose? Or half of it or something?
Half an intubating dose, probably.
So let's give like 60, 70 of propofol, or more than that?
No, more than that. A couple hundred of propofol, probably. But Sux is an interesting medicine, as many of the people that use it know. The higher the dose of it, the faster it works. And not everything is that way, right?
Because they tell you, like, give 10 to 20 milligrams of Sux to see if that works.
Right. That's true.
That's
But
what
now
they
you're
say a lot.
butting up against the time crunch, right?
Right.
And
Okay. So you're saying if you're giving 10 to 20 milligrams of sucks, it takes a lot longer for that to work than if you're given like 100.
correct. That's
How
exactly
much longer
right.
are we thinking?
Double.
Really?
Yeah.
Okay.
Yep.
So it's a slow
more
burn
is
initially.
Well,
Okay.
and so when you think about, without actually getting all the way out into the weeds on this, when you think about how sucks works, right? Sucks is what's known as a depolarizing muscle relaxant. And so what it does is it fires the muscle and it doesn't allow it to rearm. And so that's why higher dosages work faster, because
Okay.
all of those neurotransmitter end plates are saturated faster.
Right. So I didn't know that. I don't remember even reading that anywhere. So that's good to know. You're like, why isn't it working? Are you sure you gave it? Are you sure you gave it?
Yeah.
Like, I can see that conversation happening.
Oh, yeah,
in a
definitely.
crisis, and they're like, because you got a lot of stuff going on, right? Because we're not giving sucks all the time in our office. This is an emergency thing.
Rarely,
when we're
expect,
using
right?
it. Yeah, yeah. I mean, you guys are used to it. I mean, I've seen not just you guys, in general, anesthesiologists, when they extubate or remove the breathing tube from a patient, kind of put the mask on them. And I've seen a lot of laryngospasm, I feel like that way even happen.
Yeah.
And then you're just kind of just keep it on there, and that generally breaks it still because you're giving them positive pressure, right?
Yeah, it's true. And in that circumstance, what you're talking about, post-extubation laryngospasm, even if it's 99% spasmed and you hear just a little squeak,
Yeah.
that squeak that you're hearing is oxygen moving in there.
Yeah.
And so even that buys you time. Yeah.
You feel better.
And so it's worthwhile, even if it doesn't take
Have you ever
away,
seen a patient have to be
totally it buys you time.
re-intubated after their
Yes.
due to laryngospasm? So they got the breathing tube taken out?
Kind
and then
of,
they
yeah.
Okay.
You extubate, laryngospasm happens, and you paralyze them. You re-intubate because they're now paralyzed and they have to go on a vent.
Right. So you basically had to intubate them again.
Correct.
So yeah, that's a thing.
Yeah.
Yeah, no, for us, that's like one of the fears of, even doing IV sedation is, having a patient in laryngospasm and they're not breaking. And then you have to go to some sort of controlled airway, so that's one of the scarier things I would say is laryngospasm, happening. Or if a patient has a history of it, like you get that in their, anesthesia history, that's important to know.
Yeah.
So that's all helpful. But yeah, that's a lot of time on that.